Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning, everyone. First, I would like to thank the organizing committee for the kind invitation. Special thanks to Dr. Fahid for the kind invitation and the selection of the topic. It's my pleasure to be as a medical oncologist among the rheumatologists to discuss one of the emerging topics for us as a medical oncologist and for the rheumatologist as well. How we can move it? Okay, so just to put some introduction, over the last 3 decades, we have a tremendous improvement in the survivorship rate of all cases of cancer. And the mortality also has come down as well. And this can be attributed to multiple factors, including prevention, improvement in quality of life, improvement in survivorship. However, one of the major improvements that we have witnessed over the last 3 decades is the improvement of cancer treatment. We moved more toward precision medicine, and one of the most important advances in the field of oncology is the immunotherapy. So immunotherapy for us and for our patient as well is considered as a game changer for multiple reasons. One of them is the selection of patients. So we are not using the one-size-fits-all that we use with chemotherapy. So we have to use certain biomarker in order to give these treatments. Our way of assessing the response for the therapy is also different. And also we are learning about how we assess the response. New phenomena that has been emerged like pseudo-progression in immunotherapy. The duration of response, which is something unique to immunotherapy. So those patients who respond to immunotherapy, they tend to have durable and sustainable response even if you stop the immunotherapy. And this is also relevant to the toxicity because even when we stop the immunotherapy, later on the patient might still develop the toxicity. And toxicity profile also is an emerging topic related to the immunotherapy. So we are seeing a new spectrum of adverse events that we don't use to see it with conventional systemic therapy. Okay, I don't see my slides here anyway. So. This is just an example with one study that presented last year in one of the largest oncology meetings. Those are the patients with locally advanced rectal cancer. We used to treat them with chemo, radiation, and surgery, which is entailed permanent colostomy for those patients. So with the use of immunotherapy, in this study, they included more than 100 patients, and 67% of them, they achieve complete pathological response to therapy. This is something that we never seen before in patients receiving cancer therapy. Another interesting finding with immunotherapy is, like this example, a patient with melanoma with multiple liver metastases treated with 4 cycles of immunotherapy. And 1 year after stopping the therapy, still you can see the patient has sustainable response to immunotherapy. And the concept of immunotherapy, as a matter of fact, was not new. Maybe more than a decade, 100 years ago, an orthopedic surgeon started to test this concept. There was no option of treating sarcoma at that time, so the orthopedic oncologist at that time, he used to inject the patient with streptococcal toxin, dead bacterial toxin, and he noticed that he induced inflammation, and those patients who received this therapy achieved some sort of response. And since that time, one of the major part of the hallmark of cancer cell and one of the criteria of cancer cell is avoiding immune destruction or escaping the immune system. And this has been an area of intensive research over the last decades. In 2018, a Nobel Prize was awarded to these 2 scientists who approved the use of immunotherapy in cancer medicine, and it's part of a standard of care that we use for our patient nowadays. There are different immunotherapeutic approach that we use in our patient, including adaptive cell therapy, cancer vaccines, immunomodulator, virus, and other targeted therapies. However, for the sake of the time today, I will focus mainly in checkpoint inhibitors. So when we look to the cancer cell, there are some changes that happen at the level of the T cell. So the ability of cancer cell to escape the immune system through binding to a certain checkpoint at the level of the T cell. So this will make the T cell unable to recognize the cancer cell and hence will not be able to destroy the cancer cell. So the idea of immunotherapy is not to have direct effect on cancer cell, but rather is to stimulate the T cell to recognize the cancer cell and hence destroying through our immune system. These are some of the approved immunotherapy that we are using in our clinical practice, and you might see some referral to your clinic for some patients who receive this immunotherapy. And over the last few years, we have increasing indication and approval of immunotherapy over the last few years at different tumor sites. And hence, we started to see different toxicity profiles. So basically, when the immune system got excited, sometimes instead of just killing the cancer cell, it might attack our own body. So there are wide spectrums of toxicity, including endocrinopathies, neurological, and one of them is the musculoskeletal related events. So there are multiple questions that we ask ourselves, and since the introduction of immunotherapy, we are trying to also to answer these questions. Not all of them has been answered, but we have some idea about some of them. So do we really understand what is the incidence of the musculoskeletal related event in patient receiving single or double immunotherapy? Is there any risk factors? And what is the pathophysiology of these side effects? And what we should do with patients with pre-existing immune disorders. So are those patients can receive immunotherapy or it's a contraindication? One of the challenges is most of the immunotherapy trial has excluded patients with underlying autoimmune disease from the clinical trial. So the information or the data about how to use immunotherapy in those patients is lacking. However, we are learning because in real world practice, we are seeing patients who need the immunotherapy and they do have underlying autoimmune disease. So what is the optimal management for those patients, and what is the ramification of using the immunosuppressive therapy on immune-related adverse event and the anti-tumor response? So a lot of questions we are learning. We have some information. We'll try to address some of these questions during this talk. As I mentioned, there is a limited data about, at least on the level of phase 3 studies, but we have data from case report and some cohort, and it's ongoing gain of information, but overall the information that we know about the immune-related adverse event are lacking. In 2017, there was a literature review that looked for patients with, actually it was a meta-analysis, and they found wide range of incidence and reports. Some study report up to 1%, some of them report 43%, and this is related to heterogeneity of the population they included in the study. Arthralgia is the commonest symptoms that we see. Myalgia and Zika complex also has been reported, and it's a common associated with these agents. However, the needs to refer to a rheumatologist or let's say more severe form of immune-induced rheumatological adverse effect are less commonly reported. So what about the pathogenicity? Actually, we don't have well-established pathogenicity mechanism for immunotherapy-induced rheumatological adverse event, but Some of the theory beyond this is that the CTLA4 and the programmed death 1 and programmed death ligand 1 also implicated in the pathogenesis of some autoimmune disease like rheumatoid arthritis, systemic lupus erythematosus. So there might be overlapping between the pathogenicity and the targeted receptors for the immunotherapy. This is the common terminology criteria for adverse event. We have it in our clinic as an oncologist. This is it's free, it's available online. We go to this whenever we want to classify the severity of symptoms, and it's give a grade. And like in patient with musculoskeletal related event, you can start from grade 1 to grade 5. Grade 5 is death, grade 1 is very mild. One of the commonest adverse events that has been reported is the inflammatory arthritis. Sometimes can happen early, 2 weeks into therapy, and sometimes it can happen even after discontinuation of therapy. There has been different reports of different presentation. These are series of different presentation of inflammatory arthritis. Some of them involve large joints, some of them involve small joints, some of them involve the spine as well. And maybe it can categorize as some of them that they follow the pattern of rheumatoid arthritis-like presentation. Some of them, they follow the presentation of reactive arthritis. And in some cases, psoriatic arthritis also has been reported. Also, we have to keep that there are some differential diagnoses that we should keep in mind when we approach those patients, especially in cancer patients. Paraneoplastic syndrome is one of them. Sometimes just a coincidence that happened during the cancer treatment that the patient developed new onset autoimmune disease. Sometimes the medication side effect can cause such presentation, and sometimes bone metastasis can lead to erosion and presentation like inflammatory arthritis. This is what we do in the clinic, the history and physical examination, doing some basic labs, and definitely some radiological investigation. And of course, we need the help of our colleague in rheumatology in certain cases. So we have two large societies in medical oncology, the NCCN, which is the National Cancer Comprehensive Network, and the European Society of Medical Oncology. Both societies have approved guidelines for managing immunotherapy-related toxicity. One of them is the immune-mediated adverse event related to a rheumatological disorder. And this is how they classify and how they recommend, what is the recommended workup and how the management should be done based on the severity. Other presentation of these immune side effects is the inflammatory myopathies. Dermatomyositis have been reported. The presentation that has been reported is similar to the classical form, and in some cases it has been reported that it leads to distal muscle respiratory muscle involvement and death in some of the reported cases. Zika syndrome is also a common thing that we see in clinic and reported by our patient. They also lack the autoantibodies that we usually do for Zika syndrome. Most of them, they respond to symptomatic treatment, and some of them, they might need some small doses of steroid as well. Polymyalgia rheumatica is and giant cell temporal arteries also has been reported. It's the similar presentation. Even at the biopsy level, they found that if it's related to immune checkpoint inhibitor or sporadic, they share the same characteristic at the pathology level as well. And also the treatment is as patient with sporadic giant cell arthritis. Small reports about rare side effects like eosinophilic fasciitis, systemic sclerosis, and digital ischemia, single organ vasculitis also has been reported as well. This is the European Society of Medical Oncology guidelines for management. It's per grade, as I mentioned. So for grade 1, most of those patients, we don't usually need to refer those patients or do intensive workup. Most of them respond to analgesia and non-steroidal anti-inflammatory drug. However, if the patient does not show significant improvement, we would consider consulting our colleague in rheumatology. This is for grade 2. This is the grade, and this is the workup that you need to do. You do the same with the grade 1. In addition, you might consider a small dose of steroid, and you might go higher with the dose. Some of the patient, like myositis, if they develop myositis, even with the grade 2, we have to hold immunotherapy. These are the point of discussion always with our colleague in rheumatology, for which patient we should hold the therapy and for which patient we can continue the therapy and manage with steroid. For the grade 3 and 4, definitely we need some sort of help of the expert from rheumatology colleague, because those patients usually need more aggressive form of immunosuppression. So this is to summarize the action that we do. So it's a severity of the symptoms, and you go in escalation approach with the therapy, starting from simple analgesia to you go to the aggressive immunosuppression, and always consider de-escalation of therapy once the patient improved, and always consider the option of resuming the immunotherapy or holding immunotherapy for life, depend on the severity of the symptoms. So always point that we need to remember in our clinic that we are giving sometime medication and immunosuppressive, and the patient receiving immunotherapy, prophylaxis for PCB infection, prophylaxis against fungal infection, and herpes zoster. Also, we need to keep them in mind. So the question now is about what we should do in patient with already existing autoimmune disorder. So should those patients be excluded from using immunotherapy? Actually, there has been some report of cohort of patients. This is one of the largest study that has been reported. In this study, they have 52 patients. 27 of them, they have underlying rheumatological disorder, including rheumatoid arthritis, sarcoidosis, and polymyalgia rheumatica. And those patients who received the immunotherapy, as you can see, 52% of them, they develop flare-up of their autoimmune disease during their treatment. However, most of these flare-up were able to be managed with steroid, and few of them, they required holding the immunotherapy for lifelong. So as I mentioned, about one third of patients, they will express flare-up of the symptoms. A patient with established rheumatic heart disease should continue to be monitored closely by the rheumatologist and the oncologist. We don't really know exactly what would happen if you use the immunomodulation from rheumatology side and continuing immunotherapy from oncology side. What would be the interaction and what would be the outcome, but it has to go case by case discussion.
1 minute.
Sure, I'm about to conclude. So I think this is the key of this presentation. So I think in order to improve the outcome of our patient, we need to be vigilant about the side effect, to detect them early, and you start the appropriate management, and you have to have free close follow-up. And it's a team approach. So I think if we put the patient at the center, we as a medical oncologist, we need the help of other specialties. And for managing immune-mediated rheumatological side effect, I think it's the job of the oncologist to identify these symptoms early, but I think we need the help sometimes in managing those patients with these side effects. So just to recap, immune checkpoint inhibitor is evolving in cancer care and has a different side effect profile, including rheumatological adverse event. Early recognition and stepwise approach is important. Communication between oncologist and rheumatologist is crucial. And by this I conclude. Thank you very much.